Good morning, I'm Nada Mohsen, and we will be discussing multiple topics about pancreatic imaging. The pancreas is a retroperitoneal structure of mixed endocrine-exocrine function. It is enclosed in the anterior perineal space, separate anteriorly from the peritoneal cavity by the parietal peritoneum, and posteriorly from the kidneys by the anterior renal fascia. It's comprised of a head, body, and tail with a central main pancreatic duct. Pancreatic duct drains mainly into the duodenal major papilla. It drains mainly the body and tail of the pancreas, while the minor pancreatic duct, which is the accessory centurinis duct, drains into the minor duodenal papilla. The arterial supply of the pancreas comes as follows. It's divided into the pancreatic body and tail. The pancreatic body and tail are usually supplied by the splenic artery. On the other hand, the pancreatic head is supplied majorly by the gastroduodenal artery, both of which branches usually arise from the celiac trunk from the aorta. Pancreas is obliquely placed in the retroperitoneal. This is why usually visualization of the pancreas on cross-sectional imaging will require multiple slices. It's obliquely placed where the tail is at the splenic hilum and the duodenal head is enclosed, the pancreatic head is enclosed within the duodenal curvature. Most commonly used pancreatic imaging modality is the ultrasound. Being readily available and cheap, it is used to evaluate the pancreatic echogenicity. It's usually compared to the adjacent left hepatic lobe. In general, fatty infiltration of the pancreas shows increase in the diffuse echogenicity of the pancreatic body. To visualize the pancreatic head and neck, it is best to place the probe just under the xiphisternum. Although visualization of the body and tail can be a bit challenging in some patients, there are multiple techniques used to improve the visualization, and there is always a way to pass beyond the gas. Either by filling the stomach by a fluid, we ask the patient to drink about 500 milliliters of water, and then to scan the pancreas within 15 minutes from still the transverse position of the probe under the xiphisternum. The other possibility is to visualize the pancreas by placing the probe on the spleen and using it as an acoustic window. The pancreatic tail is usually visualized just anterior to the left kidney and under the spleen. Pancreatic CT protocols are usually commonly used for evaluation of pancreatic trauma, grading of trauma, scanning for neoplasm, grading of neoplasm, and additionally for inflammatory conditions and for their follow-up. Patient preparation is easily by fasting for 4 to 6 hours and evaluation of the renal functions. The patient is asked to drink about 800 milliliters of water 20 minutes before the scan. Usually the imaging is acquired from just below the costal margins to the upper iliac crests with the patient in a supine position with the arms above the head. The slice thickness used around the pancreas is 3 to 5 millimeter to find any minor lesions. And these are the phases for imaging. We have the pre-contrast images on the left, and the arterial scan is usually 40 seconds, and then the portovenous phase for the pancreas is usually 70 seconds. And this is the pancreas, as we can see here, and this is a fatty infiltration of the pancreas in an elderly patient, and this is usually a normal finding or acceptable for age, and there is no deterioration of function with this finding. For pancreatic MRI, it's less commonly used. However, it's very helpful for evaluation of the peripancreatic fat planes and for detection of fat-containing lesion and fluid-containing lesions. Additionally, MRCP is helpful for evaluation of the pancreatic ducts and its connection to the biliary system and a degree of attenuation. And this is a higher level of the pancreas, where we can see in this case there is a pancreatic bifidum, where the pancreatic tail is divided towards the spleen. PET-CT is also useful for the evaluation of pancreatic malignancies and is proven to play a major role in the detection of diffuse and focal pancreatic disease, where usually focal pancreatic disease is due to pancreatic malignancies. Diffuse pancreatic FDG uptake is usually due to autoimmune pancreatitis. And this is a case where there's focal pancreatic uptake with pancreatic carcinomatosis, as we can see. And on the other hand, there is diffuse pancreatic uptake in the retroperitoneal and the MIP images, denoting autoimmune pancreatitis. Other radiotracers have been used. Although in preclinical trials, many PET radiotracers have been used, and however, most of them are promising, enter the FDG. Other radiotracers in preclinical trials on many PET radiotracers have been done. However, the most promising have advanced into clinical trials. In 2018, the FDA approved 5 PET radiotracers, which are used for oncological imaging. Most commonly noted on the market is 18-fluorodeoxyglucose, FDG, and the other one is gadolinium dotatate used for neuroendocrinal imaging tumors of the pancreas.